Hey everybody, Ed Bowder from the Med School Medic Podcast, medschoolmedic.com, back with another 5-minute pharmacology refresher. Today we're going to talk about epinephrine or adrenaline. Now, the dose you may see regularly in your truck or in your equipment bag is a 1 milligram of 1 in 10,000 concentration. This is usually what we give in cardiac arrest. The reason we give it is we want to stimulate the alpha receptors in the blood vessels and in the cells, and we want to increase cerebral perfusion and myocardial blood flow. Now, the whole point in this, someone in cardiac arrest, they have very relaxed vasculature. So we want to constrict that and try to get more blood to the heart, more blood to the brain. This drug, this concentration, has some very questionable beta effects. We're more concerned about the effects that this drug has on the alpha-1 adrenergic receptors. Now, typically we give this drug every 3 to 5 minutes in cardiac arrest. That's per ACLS, and that's something we've been doing for decades. But I have to tell you, there is very limited evidence that this drug every 3 to 5 minutes actually increases ROSC or survivability. This is a drug where the data is still kind of out on it because we haven't really researched it all that much. We know that it has the chemical effect on the blood vessels. We just don't know that it increases ROSC or increases survivability. But for right now, every 3 to 5 minutes, epinephrine 1 in 10,000, 1 milligram, super easy to give, just one Bristojet. There is another concentration of epinephrine that you're probably going to find on your units or in your med bag, and that's the epinephrine 1 in 1,000 concentration. We typically give this for anaphylaxis. We give it intramuscularly or subcutaneously. What we're looking for, again with this drug, is that alpha-1 adrenergic action. Someone who is anaphylactic and they're in a shock state, they're going to be just systemically vasodilated, right? You go into a shock state, everything kind of opens up, and that's how you get that hypotension and that tachycardia. So we give this drug 1 in 10 IM. By the way, 0.3 milligrams is of 1 in 1,000 is the dose that's in EpiPens as well. So we give this drug to lessen the vasodilation, cause peripheral vasoconstriction, try and get their blood pressure back up. This drug is going to keep their heart rate still kind of high, but the idea is that we improve their blood pressure. Epinephrine also has the effect in anaphylaxis that on the front end, it's going to reduce the anaphylactic reaction. You're going to see a drug like Benadryl, it's going to affect all the circulating histamine that's already out there. Epinephrine 1 in 10,000 is going to reduce any future histamine from getting released, and that's the important part. It's also going to increase vascular permeability, and what that's going to do is that's going to allow more oxygenated blood to get through the system. Now, again, the 1 in 1,000, this is a patient, if you have a patient who is anaphylaxing or someone who is a very profound asthmatic, you can also give epinephrine 1 in 1,000 to these patients, someone who has just a very diffuse wheeze, profoundly diminished breath sounds throughout. You can give 1 in 1,000 for this beta action. Now, the 1 in 10,000 has some questionable beta effects, but the 1 in 1,000, because it's more concentrated, that has some pretty good beta effects. So what we're looking to do is that's going to cause bronchodilation in the lungs and allow more airflow in the lungs, allow them to breathe much better than they were initially. This is why we give this, again, in anaphylaxis when someone is bronchoconstricted and they're wheezing. We want to give that drug for this compounding effect where we're reducing the amount of histamine that's circulating through the body. We're also allowing this bronchodilation to occur. Now, you're not going to give this drug independently in anaphylaxis or in someone who's a profound asthmatic. You're going to give it in conjunction to, say, a duoneb, or you can even give a drug like terbutaline on the back end as well. Now, so we give this drug IM, sub-Q, causes bronchodilation, allows them to breathe better. After you give this drug, you're going to want to monitor the patient's breath sounds, their blood pressure, their heart rate. Because again, we are giving this fairly effective catecholamine that's going to increase their heart rate, and it might actually increase their blood pressure and their respiratory rate as well. So after you administer the drug, you want to keep monitoring your patient and make sure that the desired effects that you're giving have actually worked. So 1 in 10,000 for cardiac arrest, 1 milligram every 3 to 5 minutes to increase that cerebral and myocardial blood flow. Epinephrine 1 in 1,000 for anaphylaxis, asthma, and the idea behind that is we're trying to bronchodilate the patient, and we're trying to reduce their peripheral vasodilation. So we can do that. We can get their blood pressure back up. We can make their respiratory rate much better. That's your 5-minute refresher for today. Be sure to follow us on Facebook, like us on Twitter, subscribe down below for YouTube, and subscribe on iTunes. We'll see you next time.